My name is Dr. Anthony Ngatia. I'm on the One Health Lens podcast, The Journey to UHC. Today, I'm going to be discussing artificial intelligence in healthcare. It's an intriguing discussion, and where is the journey on artificial intelligence? We'll discuss a little bit about the definitions, the applications, and what the future looks like. Please join us. Thank you.
Hello, welcome to the One Health Lens podcast, where we have conversations on global health, public health, and the road to universal health coverage. I'm your host, Dr. Diana Wangari-Getao. Today we have, as always, an important guest. In fact, this is not an important guest. This is an old-time friend. In fact, the producer, Kevin, mentioned we look like brother and sister. We'll be...
I'm lucky.
We'll be having a conversation about AI in healthcare, artificial intelligence in healthcare. I'll let him start by introducing himself.
Thank you for having me, Wangari. My name is Dr. Anthony Ngatia. It's a pleasure to be here. Yes.
For the years I've known you, right now I understand you're doing a lot of coffees and whatnot, right? But what's your background, right?
So I would call myself a public health practitioner, but I'm more or less, my main focus right now for the past 1 year has been actually artificial intelligence in healthcare. But my background is I'm a medical doctor by training. I think we studied in the same alma mater university, so where I did public health, global health, and I joined an NGO in Kenya, Clinton Health Access Initiative, where I started as an analyst, became a program director, and there mainly a lot of data analytics, a lot of crunching numbers. I learned a lot of skills in Python analysis, and that's how I got into this space I am trying to get into right now.
Big terms, Python and whatnot.
Yes.
You know, it's interesting. I was having a conversation with someone who said they're also interested in artificial intelligence, but in agriculture.
Yes.
And then he was relating his experience working with farmers. And in this, I suppose it was a forum where one farmer said, artificial intelligence, you mean artificial insemination? Actually, this guy stands up and corrects him. Corrects him. He's like, no, don't you mean,
Yes.
But what is it, right? What is artificial intelligence?
So maybe, I mean, in the simplest terms, it's just basically algorithms and systems that are made to do things that are traditionally require human intelligence. So it's getting a computer to see. So it's called computer vision. So the way cars operate, and we'll get into healthcare, that's computer vision. Making decisions, so using like data to get it to recognize patterns that traditionally are things that human beings recognize. So find this kind of pattern. Those are things that are traditionally human. So artificial intelligence is that. Yes, very simply. But I mean, I think also the other confabulation is ChatGPT and all these things. So, I mean, that's generative AI. It's a subset of AI, where here the point isn't to like make a decision or to get it to see. It's for it to generate new things. So they've been taught all the things we have, like basically on the internet, and then you give it a question, and then it generates what's something new. But it's basically
a cover letter.
Yes, generate a cover letter. But it's basically just what has existed before, that it's actually now the same math, but now being applied to generate an output from words. Yes. Okay.
So I'm wondering where to start, because part of me wants to go the direction of, you've already, in fact, I've learned around generative AI and whatnot and the breakdown. But maybe let's not make it complex. We have understood it's essentially computer vision, right? And in that, there's a lot, right? The same way in medicine, there's a pediatrician, there's a lot. So based on which industry you work on, artificial intelligence could be a lot of things. So it's not just ChatGPT, right? Okay,
exactly.
Fine. So when we come to healthcare, artificial intelligence exists in healthcare.
Wow, it does, and it has for a long time.
Yeah.
So let me start. Maybe let's start with the most common one. Would be around imaging. So when you've read CT scans, MRI scans.
Yes.
So you see, like it makes, like you can see even 3D generation.
Yes.
A lot of those ones are also machine learning algorithms.
Yes.
So each manufacturer of these machines has created an algorithm that can help them make this clearer and easier for the doctor to interpret and clearer images. Ultrasounds have even machine learning algorithms to help them reduce things like the noise in the in the machine. So machine learning, AI has already been used so many times in health. So the easiest would actually be to say, look at imaging.
Yeah.
However, it's also used in so many other places. I'm sure I've listened to your podcast recently a lot. So one of your guests here actually even talked about their work at KEMSA in Ndwiga. So when they're talking about their system, he actually mentioned machine learning algorithms helping them do forecasting. That is the same. It's AI being used. So the way you should actually look at these technologies is it's not a new thing, or it's not like they've been there from the 60s. It's just that they're now being deployed more and more. But it's like Word. It's like you can use Word to write a CV. You can use Word to write a proposal. You can use Word to write something else. So it's a baseline technology that can be used in so many ways. But it's already being used in healthcare.
And actually, that might be a good question to ask about machine learning algorithm, because there's someone who'd ask, is machine learning different from AI?
No, it's a part of AI. So if you look at, the big aspect is called data science. So data science has statistics, all these things. AI is a subset of that. AI is now where basically these algorithms and systems is you train them. You train them to get a certain output. So the same way you train, like we use computer vision. You've trained it by showing it images of dogs, and then not dog. So a computer now knows
this
dogs,
is a dog,
this is not
dog.
a dog. So when you show it something, it'll show it my image. It says not dog. You show it a dog, it's a dog. So with some accuracy, but there's some training that goes into it. So that's what this machine learning algorithms are. It's different ways of training the machine to eventually understand what you're trying to do.
I like that, because then that also now explains why it's important to feed it data and information.
Yes.
Because the only way you recognize is a dog versus just like a child, right, is by information, right? You have to show pictures of dog. Then at one point it's like, oh, dog, then not dog, right?
Exactly.
So it's the information you feed into it that then is able to give that knowledge or that intelligence to say this is this, or to interpret that if you are using, say, as you give an example of an MRI picture, that if it picks up this or this, it could be this, right? Because that information has been fed into it, right? Okay. So you say as part of your sort of background has been a lot of data analytics, right? And I know you've given the example of imaging as part of the uses of artificial intelligence. But is there, before we even get to more medical stuff, is there other applications of artificial intelligence currently? Simpler applications?
So let's even use the same example of like what KEMSA is doing with this artificial intelligence and machine learning. So you have all this data from health facilities. We have over 6,500 facilities reporting every month. You can summarize all that data and look at it as, so average mean is X for all the six. But when you're trying to look at all the 6,000 facilities and individually try and compare, it becomes a lot of work. But machine learning now, you can actually disaggregate it, and then it takes all these 6,000 facilities and starts looking at the pattern. And you train it to actually say, okay, if you give them X amount of, say, contraceptives, this is the output, and this is what remains. And that is all in the data. So what happens is that once you've given this output and you want to tell it, estimate who stocks out of contraceptives based off what we've issued as KEMSA, then with the trained data, it can see and say, okay, if you give them X over Y of this months and this kind of trend, these guys will stock out. Yeah. So now you apply that to real-time data. So you can do that yourself as an analyst and analyze and say, if this happens and this happens, you can get stock out. But now with real-time data, now I have to start doing it myself. But with this machine learning algorithms, what happens now is now you've trained it. The next month the data comes in, you just put it into the algorithm, it's already learned, and it knows if this and this happens, this one will stock out. So it will tell you this one is more likely to stock out. So what it does is it moves you from seeing what happened to being more predictive. Like then in future, this one is at risk, this one is at risk. So then you can actually adjust correctly and actually give them either more contraceptives or less. So that's how to look at it, like the actual implementation. So to fix those problems, that happens quite often. So contraceptives, for example, heavily rely on this. Other programs also rely on this kind of analytics to help improve. COVID was also a good example of this kind of AI use. So there was a lot of models. And I was in one of the task force.
Big meetings.
Yes, big meetings that you and your co-hosts keep fighting about.
Exactly.
So I was in one of those task force, Dr. Akwale's task force. And what
Willis.
actually, yes.
It's been a while. I also need to call him.
Yes, he should come. He's a very great guy.
Yeah.
So one of the things was a lot of people actually, I think for the MOH in general, models became extremely common. So a lot didn't work. So a lot said this is going to happen, this is not going to happen. But what actually happened was people were actually exposed to all this information. So like if you're looking at, if you go to the Ministry of Health, a lot of people saw models. They were told things like p-values. Now it stopped being
something in their textbook.
Exactly. Actually they started looking at it in real life. So, and actually starting to estimate, okay, do these models work or not? The ones that actually worked very well and actually provided a lot of insight. The ones that didn't work actually taught people, okay, this is why we didn't have enough data. And that's why this is this guesswork or this estimate didn't show up the way it is. So I think the learning on how to use machine learning or AI algorithms in general was COVID actually fast-tracked that. So yes, we worked a lot remotely, but even models were introduced into the health system. So it's not new. They exist. So they exist everywhere. I might not even know everything. And maybe even just to let me give another example of for even imaging. Like the TB program actually is like an impressive use of this AI technology.
How so?
So the TB program uses this computer-aided diagnostic device. So it's a small X-ray device. It fits into a suitcase. You can carry it anywhere.
Is it?
Yes. You can go with it so it can be used in prisons. And you just line up all the prisoners and it takes an image. It doesn't need a film. Captures, and then it tells you a score of whatever the score, and the program has a number on, okay, if you have this kind of score, then we do a genetic test to actually see, do you actually have TB. But that scoring for TB can also be used for, let's say, cancer, and same machine, it can be used for so many other things. And it's portable. I mean, it's not cheap, but it's portable. So here is a device that is using this machine learning algorithms, and just let's use AI. Let's just use AI for now. Yes, so that we don't say
this versus the other.
Yes, so it's using AI to actually score patients to say, is this TB or not? So it gives you a score 40, maybe 60, and then from there the algorithm kicks in. So what's this doing? Number one, you don't need radiologists everywhere. So this can go to the community. It can go to prisons. It can go anywhere. The person who's running it doesn't
need to be highly skilled and whatnot.
And then you can actually automate so many things. But I think even most importantly, what this actually does is this saves so much money in terms of, because the gene expert test is not cheap. So it increases your yield on gene expert, because if you've done this test on hundreds of people and this 40 people actually have a high score, and then we test them, then you actually have a higher chance of getting, confirming this is positive, and then even mapping out and saying, is this drug resistant or whatever. So if you're using AI, and you can actually reduce so many costs in so many ways, because here is, we've saved on a radiologist. We don't have enough. So please, it's not that we've fired radiologists. They're already too busy. So here's a test being done where we don't need these highly skilled people in the community. You've saved on the expensive confirmatory test, because these 100 people might probably have been given this test, and now you've only tested them on 40% of people, where this was actually used as screening. And you're even saving on, we've done this in the community, we've done this in the place where the patients didn't have to come to us. We took a small team of people to them and actually did that. So here is a national scale program, the TB program, doing this amazing use of AI. And there's no one talking about it like we're using AI.
Exactly. Yes. I mean, a lot of the things, even the KEMSA program that you mentioned, it's until I had that conversation that it occurred to me that, actually, it's advanced in many ways, yet, of course, because then people don't focus on the details, right? Yes. But the fact that what you're explaining is a fact that if the machines, and I don't even want to say the machines because then it becomes us versus the machines, right? But if you're able to train a computer and say that given, say, let's even use antibiotics as a general term, right? Antibiotics that given a certain area, for example, experiences more certain kind of infection. No, let's go with malaria. Forget antibiotics, malaria. Yes. So there are areas where they have malaria more, right? Than this other area, right? So given all this information tends to come to a certain system, right? So as the machine is being trained, it should be able to say that, in fact, the area that you get more malaria diagnosis is where then you should be able to stock up. And it tends to go up, say, in June, right? Yes. So you should be able to know by the time it's May, whatnot, right? Yes. And that makes it easier, because then in terms of if you're thinking about from a patient perspective, you then would have malaria drugs in a facility where it's needed as opposed to where it's not needed, right? Yes. So there's a certain efficiency that comes out of that. And what I'm also hearing is that a lot of the systems we're using, not a lot, but like as you say, the TB program, there are already systems in place that use artificial intelligence. And because of that, what we have been able to achieve is not just the efficiency in information processing, but it's also, we have been able to say we don't need the bigger equipment we used to have before, but since you have trained something that now can fit into a suitcase, take it there, then from that it has been trained to say, okay, fine, chances are this one has TB, this one doesn't, right? So from that, people line up, at that they are able to get screened, and then based on the number that pops up, 90% versus 80% as an example, then you're able to say, okay, since this person is say at 90%, then they can now go for the more expensive test, as opposed to what used to happen before, which is first you'll come, you say you're coughing, then blood will be taken, then you go for imaging, and still you'll still be taken for further and further tests, right? So there's a certain level of efficiency. Cost has been, could drastically be reduced, and all that it takes is essentially a lot of just training, right? Yes. Up to that point, we're okay.
Very good.
We're okay.
Very good. Spot on.
Now, the big question comes in. The same way most people think the word artificial intelligence is fancy, it's beyond us. And you've just explained it's something that's happening, right? And you've even said it's happening in TB program. TB, we've been having TB programs since. Okay. Now, the issue becomes me as the person who lives in the village, me as the person who lives just here in Nairobi, say in wherever place, right, where I cannot necessarily afford to go to high-end facilities and whatnot, right? How does it then get down to me? and why I ask this, right, is I see multiple challenges, right?
Yes.
I see a challenge in, I don't necessarily think that this technology is available to every, say, hospital, every provider, right? I feel like the examples you're even given me is program, right? So then, is there a space where this kind of innovation moves to just a common mwananchi, and how does it even get there, right?
Okay.
We start from there.
Okay. So, I mean, I think the programs, the reason they actually do it is, one, they're funded. Second, they have a pain point that they're trying to address. So the uptaking of this kind of technology, I think it's a lot faster for them because of these two main reasons. There's some money around, and also it's a pain point. Like, if you can improve the efficiency, you can do more with the money you already have. So, yes, please. So let's now back to your question. Yes. When it comes now, so you're an individual, you're already being affected in so many ways by AI, and it already, one, it can reach you at a personal level. So there are all these different chatbots on mental health, on how to help you. So like WHO have one, it's called Sarah, where it can help you lose weight, help you quit smoking, and all those things.
Can I steal it in your career?
Yes, success rate we don't know, but I mean, there are all this. So at an individual level, AI can reach you directly through your phone. Like, if you have a phone, AI can reach you, and actually this kind of chatbots can actually be very, and there are several. I think even MOH has one for mental health, like it's WhatsApp based. I don't know if they work. Then that's a different question. But how does it reach you in the health facility? So those are, it's work in progress, but even things, for example, let's even get to imaging. There are small point of use ultrasound. So the small devices fit in your hand, you connect it to a phone, and you can actually carry out ultrasound. So the algorithms in it actually can turn a nurse into a very good radiographer now. So she can easily take all these different ultrasounds for pregnancy within a facility with this small device that costs a few $1,000s compared to the big ultrasound. So it'll get your facility, even if your facility has no electricity, it's just charging. So and you can see there's some tests. I think there are places in Kajiado where these things are being piloted, and they're already happening. So it's already getting to you as an individual. I think maybe the way to actually, as a common mwananchi, AI already affects you. And for us, I think, even in Africa in general, AI is not nice to have, it's a must have. And let me explain why. So let's look at our human resources. So right now we have a doctor strike. Being a doctor, I think I'll be very, very biased in my opinion. But the thing is, we don't have enough healthcare workers. We don't have enough doctors. Even if the government doesn't want to take up the interns, we just don't have enough. And please note, globally, there are not enough doctors. So our doctors will eventually move to the UK. They'll do their PLABs, USMLEs, and they'll move. And if you actually, do you know the saddest thing, just to tangent a bit, do you know when, so you're a bit younger, but for the elderly,
thank you.
yes, for the guys who finished who graduated in the 90s and in the 90s, there are classes where majority of their class don't live in Kenya, like as in like 60 to 70% of your classmates are in Botswana, all over the world. We actually were lucky in that majority of our classmates are people who we see around. So I think it's going to reverse back to like what those guys who graduated in the 90s, where people will finish and 80, maybe 60% of classes move to the UK or wherever to serve. But I was tangenting back to the important issue. So we have a huge need of healthcare workers, and that's not going to reduce. The West will still keep stealing our nurses and our doctors, not even just the West, even Saudi Arabia.
Yeah.
We're exporting nurses.
I mean, you've just said Botswana right now.
Exactly.
So, yeah.
No, at least I think now they're happy with their own doctors.
Okay.
But yes, as in Kenyan doctors actually built the Botswana health system. So I think yes.
And yet it's the country where UHC has really, progressed to a point.
Yes, but it's government being serious about building their own capacity.
Yeah, expenditure is actually not an option.
Exactly.
So, okay.
But now, so in Africa in general, maybe there are a few countries that actually have their ducks in a row. Yes. But in Africa in general, we will always have this gap. So the need of upscaling is not a nice to have. So let's look, for example, WHO has a requirement of 1 ultrasound to be done in each pregnancy. Yeah. We have 1.5 million births. How many obs-gynaes do you think we have in this country?
I don't think it's 1.5 million for sure.
Yes. So they will not be able to do 1 ultrasound for 1.5 million women. So let's be honest. Even this, so we have a 96% ANC rate in ANC1. Yes. ANC4 drops up markedly, but ANC1 are around 96%.
Most people go for the antenatal care visit. Okay,
so,
the first one at least.
Exactly. Yeah. So this 1.5 million, they will see a nurse. So if we're saying, okay, we want to do an ultrasound on each of them at least once, then nurses actually have to do the ultrasounds. So if we're going to get nurses to do the ultrasounds, then and they actually can become the first port of screening. Yeah. You can only do this at scale by upscaling nurses using either AI technology, ultrasounds. And that's the case. And when you're talking about scaling all these services for PHC and UHC, we can't say we'll rely on our healthcare workers as they are. We will never have enough. Yeah. And government will never hire enough.
Absolutely.
So with that, we honestly have to start on the use of AI to upskill healthcare workers. Yeah. It's not good to have, it's a must-have.
Absolutely.
So I think the discussion shouldn't move around from AI is taking our jobs. It should be how do we ethically and responsibly actually do it. And also, how do we actually make sure that there's one thing called AI, bias in AI.
Exactly. Why it cannot recognize in Kenya or a black person.
Yes.
Anyway, all
yes. So bias exists, and it's also because of the data. The training data is mainly from certain areas of the world that are not Africa.
Yes.
So there's a need to actually also improve on these AI technologies by providing our data and also critically looking at AI. So the question is, if we're introducing AI technology now, who's going to review it? Is it PPB? Is it KMLTB?
No.
So we have to do So we have this AI X-rays being used all over. They make sense. Who's reviewing it to say that this machine, this algorithm actually works here?
Who is there someone reviewing it?
Right now it's mainly the program, but the program also has an incentive to see that it works. So you need an independent third party. So does PPB have that capability?
No, probably not.
And does the lab board have the capability for diagnostics?
Probably not.
So, and that's where we should move away from AI is bad, or we can't trust it, to how do we actually improve our capabilities to actually be able to absorb these technologies in a sense that make in the right sense for us. So the Pharmacy and Poisons Board needs to have the capability of, maybe not them so much, but more of the radiology, the radiation boards, the lab board. All these guys need to have these technologies to actually, or capabilities to actually be able to interrogate this kind of technologies. And that's where we should move to, away from is AI bad or is AI good? Yeah.
In fact, you've answered so many of what was bound to be my question about, AI taking all our jobs away and it being bad. Yet, I think the main sort of message should be around AI is actually the future, and it's not just a slogan that people use. It's because then if you're talking about universal health coverage, right, and universal health coverage being essentially that if you need healthcare wherever you are, whether you're in Mandera versus you're in Malindi, you should be able to access that service, and it's quality service without you having to dip into your pockets, not dip into your pockets, but selling your land and whatnot, right? Yes. Essentially, that's it, right? So if I'm a pregnant woman who needs to get my ultrasound in Mandera, I should be able to get it, right?
Yes.
And we all know that, again, as you're saying, that we won't have enough doctors anytime soon, and also we might not be able to afford all the big equipment anytime soon. I mean, it's been decades. The first, this big machines, before they get there, it takes time, right? So then it's looking at it and saying that, one, let's take it even from a more policy government perspective, we need to incorporate artificial intelligence and its applications, whether it's diagnostics, whether it's within the systems in just processing data for procurement of drugs, right? This might actually make a difference, because then in terms of predictions, there's only so much human being can do, right?
Yes.
Real time. There's only so much you can process and be good at it at the same time, right? So the only way we'll default is actually a computer, which has shown that it's able to, right? And because of that thinking, then it means that we have to be open to saying that we don't want a machine necessarily a program that comes from the West, but we want a program that, even if it has come to the West, from the West, where it knows us, right?
Yes.
It knows us, and that's where the openness comes in, right? That we're willing to give data, and it's not giving data in terms of just for the sake of it, but it's ethically, right, within a controlled environment with supervision and whatnot. But for that supervision to even happen, for it to be ethical, that it's not a newspaper headline that our data is being stolen and artificial intelligence is bad, there has to be an openness, right? There has to be goodwill from different levels, whether it's government, private sector, different decision makers and key holders, so to speak, gatekeepers, that we need artificial intelligence, right? And for that, then we need to think about building capacity, so that then when people are coming and saying we have this program, we have this, we internally are able to actually guide it, right?
Yes.
Okay. So then, in that case, what I'm hearing is also an opportunity, right?
Yeah.
A big opportunity in terms of we don't have to fight about the old, say, if right now I can do my TB, say, screening with that suitcase, and I'll use it just as a very general example, right? That suitcase device, right? That means I don't have to then say I must start my big hospital, right? I can be the doctor who has a mobile clinic, right? In I used Mandera before, now in Bungoma, right? So then in that case, are you seeing more and more people, especially from a provider side, right?
Yes.
From doctors, nurses, who are open to using the technology, right? Because it could be there, but if people don't want to use it, it's a different issue, right?
Exactly.
So are you seeing more people more providers willing to take it up?
So to be honest, I think we're in the early phases, but here are the pressures. Yeah. So number one, government is just not going to absorb all the doctors being trained by all the universities right now, and they've been signaling this for a while, and this strike also is just showing that they're not that important, rather to the government, despite them being important to the system. There's a push, and where the absorption of AI. So the reason why policy needs to try, it's hard for policy to keep up, is that AI changes very quickly, and all these things are changing rapidly. So even when I'm talking about like ultrasounds, handheld ultrasounds being very good, yes, they're improving in their ability to diagnose, but also they're reducing in price. So what eventually we'll start seeing is that, let's say SHA now kicks in. It's now working, and government has capped money on X. This is how much it will cost for everything. I think one of your guests, Brian, actually showed the health system can be practical. You say
I'll only pay 1,000 for this.
We'll figure it out. AI is how we'll figure out even faster. It might not be the older doctors or the people the geezers like myself who actually figure it out. It may probably be these younger guys, because here's the thing, there's pressure to actually meet this cutoff. X shillings for an X-ray.
Yes.
The absorption of technology to actually meet this number will actually happen in that way. So it'll be either young doctors, young nurses learning how to use AI, and it's an opportunity. So I think they might actually be first in line to actually do it. Maybe not in Kenya, but in Africa, I think, despite how people think...
why not? Maybe not in Kenya. I think Kenyan doctors are up to the task.
They're up to the task.
Yeah, they are.
But also, the other thing that Kenya has that other countries don't have is we have very restrictive laws. We have a Data Protection Act.
Do we?
Have, yes, that is very clear.
2017 or 2019.
Yes, in fact, I hope you got my consent to put my photo and my face on your podcast.
I tell you.
So, but there's all this, we have all these restrictive laws. And I think, I don't know if that is pushing or helping. We do have a very educated workforce. We have very smart people. So yes, it could happen here. But my push is just, my point is, in general, a lot of the discussion is, the West is doing this, this is happening. Our need for absorbing AI is not going to be like a big company saying, we have the cool thing here, this is where we're moving. It will be absorbing this because of needs. So even the examples I've given you, it's need-based driven. Like we needed to reduce the cost. We absorb this technology to reduce the cost. And that'll be the same thing. Like I think how AI is going to be absorbed in Kenya and Africa in general is that there's a need. We have 1.5 million women who need to be who need these scans. We might absorb point of use ultrasounds because of that need. It'll be SHA saying we're only paying 2,000 for an ultrasound, and you with your large machine and you can't really make money off it.
Yes,
it'll be young doctors saying, we'll use this point of use ultrasounds to actually do this ultrasound for that 1,000 shillings where I still make my profit and all that. So the absorption will happen not because of it'll because the need is there, and this actually sorts the problem. And that's why if I was a policy maker in Kenya, I need to be in front of it, not to be restrictive. We already have enough restrictive laws, but to be supportive and to be more understanding, because the challenge with healthcare is if you're now making a mistake, so let's say this point of use ultrasounds are now being used at scale.
Yes.
And they just can't get it right for some placentas, which are a bit smaller than they usually are in the West. Then we could just be doing things wrong. We're getting things, let's say the female length. Here it's a bit different compared to the West. And we're here saying, no, this kid is now off the chart and probably is normal. So even our numbers will have to improve and change when we're using these things at scale. And that's actually where, as a policymaker, I'd be like to support and to provide guidance. But the absorption, it'll happen not because it won't be top down.
Market forces.
Market forces will push for it.
Absolutely. I mean, if I was listening to this, I would look at it as an opportunity.
Yes.
One, whether it's a doctor, a nurse, doesn't matter who it is, right? You're working in healthcare. It means instead of you trying to fight for not your rights, but essentially following the path which has always been, I work for this years, I aim to be in a certain hospital, which is the big known facility in whatever area you come from. You should be looking at it and saying, how can I adopt the newer technologies so then I can stand on my own, but more importantly, I can actually meet the need that's there, right?
Yes.
Because I'd imagine in many cases, and it's not even imagination, it's knowing this, that most patients we see tend to follow the provider, right? So they tend to follow either their doctor, or if there's word of mouth referral that Anthony is quite good, right? You might have come recently, but he's quite good. He takes more time, right? If I go there, I don't leave with a bag of medicines having been charged XYZ, right? So if you come up and you say, okay, I'm a young medical doctor, young healthcare professional who's using these different kinds of technologies, and saying I'm setting myself up so that one, the efficiency created, one, brings cost down for my patients, which then this cost potentially can fit into what maybe the national, the social health authority and the new social health insurance fund, the cost that they might say this is what will reimburse for services. So then I look at it and say, maybe I can do this, but not by doing things the old way. It's I have to figure out what's new, right? Because that's part of the innovation, right? And that means also, I think there's an element of also, I think in many ways, education, right? Education to come to the providers, policy makers, so that it's not, we are fighting this thing down, right? It's education also, just public, that it's not all bad. In fact, it's not bad. It's about just regulation, I think, from what I'm hearing. It's not that they're here to take our data away so that they can make an experiment out of our data. As we say, it's also that it's not taking our jobs away, right? I don't necessarily think there'll be a point that we don't need human touch, especially for healthcare, right? We'll always need human touch. Even sometimes, if you're positive, we don't take what has been generated out of the system as truth. Sometimes you have to check, and it escalates, right? Because take the example of the TB patient, right? If you've been scored this, you still go for gene experts, right? And there are certain more steps. It's not that because you're scored this, you start medication immediately, right? So there'll always be human element. So it's not that it's taking away our jobs. It just means perhaps we need to go a step further. You'll be the guy who all these results come to you and you verify. But then for you to be that person up there, you need to have that capacity. So instead of fighting the system, what is inevitable, then people should be thinking that, how do I learn? Right? How do I build the capacity that if I am the medical, whatever body it is, whether it's labs, whatever it is, then how is it that then I am working on a unit, right? That's not fighting, but training people, right? So then in that case, in my, at least as in my mind, I'm thinking as we're talking about universal health coverage, Digital Health Act. Are you familiar? Do we have such plans, or is it too early still? Because I know the emphasis has been really much on social health authority. Let's get the money in. You know, are those the conversations we're having? Has there been whispers?
So, no, we're not having those conversations. So, just to... Part of the challenges is, like, even in the growth of these technologies, it's very recent. So, I'm not going to go to Nairobi University and get AI in healthcare training right now because there are not that many practitioners. It's not there. But you will have all these different statisticians who are pivoting from, I've done medical statistics or I've done statistics in general. I'm now interested in this space called artificial intelligence. Now I do modeling and all that. That is already happening. The way I think education will happen, and I still think market forces will drive this. Online education exists right now, so there are people who need to go to class, but to be honest, you can learn a lot of these things by yourself. YouTube University exists,
absolutely.
And also all these big cloud space service providers, from Google to Microsoft, all of them have certified trainings on how to do machine learning, AI, because they want more practitioners, and the only way they can do it is give it for free, come learn, start using our systems, start using our cloud services, start using our algorithms. So there actually is a lot of available free online training for you to learn these things. Yes, it takes some self-drive and motivation, but I think I'm a young clinical officer. Government is telling me wait till 5 years from now to even think of doing an internship. Yes, I have the time to actually study some of these things myself. I'm a young nurse. I've just finished internship. I'm registered. No job for me. Yeah, you can learn this yourself and just see, because knowledge is power, and the opportunities already exist, and it's just now how these two start merging. So that will happen on. I think like self-driven learning will definitely be the route to go, and we have a lot of young people and a lot of young smart people. So learning these things is the reality. Like as in, I keep getting impressed by the kind of things young people just learn for themselves. So that's one. The government will do the training and all that is a bit harder for them to do, because as it is, they already don't pay for you to do your masters in anything. So I don't know when they'll actually catch up to this. So it's part of the, and you can see my bias. Maybe
I know the bias is quite clear.
Yes, but I mean, the use will already start happening. I think it's. I wouldn't say that it has to be. You have to go for
further education and whatnot.
Right now, it's such an early phase. The use of it. So, for example, and back to even your example, one of the things that definitely need to be built here is like on decision support. So, like when you're looking at guidelines, so we have guidelines saying this, then that. These tools can actually be trained even on your medical records, which are already electronic in a lot of places, to help with decision support. So that means I won't need the highly trained consultant to do some decisions, because based off these medical records and this training and using national guidelines and keeping in line with SHA, let's say, guidelines on this is what is reimbursable, this isn't, the system can actually help you make this decision. So when you're saying the linkage will already happen because of that. Like if the guidelines for SHA are extremely rigorous or extensive, insurances have the same thing. So the reason why it takes such a long time to get your reimbursement is that they're trying to did you meet the criteria that was set up for this? All that can already be automated with AI, and that's actually part of the value addition of AI. So in insurance space, AI will immediately change all these different claim providers. AI can already start doing that even right now. It's just a matter of, are they willing to actually do the switch?
That was going to be my final question around the willingness, right?
Yes.
The young people might be studying, even they don't even need to pay. You know what, YouTube University is there, and even if it's not YouTube, as you're saying, there's multiple platforms whereby you can learn today, right? But then the question always becomes, and jobs of the future are within that space, right? Most of those jobs are seen in the West, right? Because someone might wonder, if I learn, right, where do I apply it locally? Right, that willingness is a big issue. Willingness, whether it's from a government, private sector, becomes a big issue. I mean,
so this is actually, I think this is what will happen. So when you actually have this knowledge and this understanding, these young people, the pitch to the insurance company is that, hey, we can use natural language processing to process your claims, and it'll save you 30%. If you say that, like, who won't listen to you?
That is the key. That is the key.
Yes.
That is
so
the key.
It is, and it will just be one of them switching, and the rest will follow suit. So it just becomes, when there's a critical mass of people saying, okay, look, if you use decision support algorithms in your clinic, you can actually get more people to actually help you, and you can do more. If you're using natural language processing of claims, you can actually do all the savings as an insurance company. Then the switch starts happening. Right now, the challenge is that the number of people actually who are trying to have these conversations with the companies are not that many. And I think they'll increase, because the challenge is, yes, you might have very good data scientists and people who know algorithms, but people who know all this plus the healthcare system are not that many. So eventually we will have now young doctors, young nurses, young clinical officers, and all these other taking up this space. And that's how we'll actually see, because AI is already in use. And the pitch was also the same, like The reason I think KEMSA actually switched is this is a faster, smarter, quicker way to do things than manually doing all this work. And that actually made them build a system that actually makes sense.
Absolutely. Yes. And I mean, brings the cost down as well. The initial capital might be high, but over time, when you look at it, then the savings are enormous, right? Exactly. So it's also a factor of just packaging, right? So that it takes, again, it's always... one person has to take the risk. One county in Kenya has to come up and say, or someone has to go make a pitch, I think, to a governor and say, you know what, just doesn't have to be the entire healthcare system. Pick whatever niche it is and say, you know what, this is how much savings we can, whether it's in terms of just cost to... incurred, whether it's just a factor of you don't have to worry that when can you get the next specialist here, right? Because they're not enough, right? It's not that we are saying replace them, forget about them, it's just, they're not enough. So someone has to take that as a not even as a concept, as a proposal to one governor, one small unit, and say, this is what we're going to do, right? And that's sort of the mentality people need to have.
Exactly.
Because once that market, there's enough, not even demand, but that push, right? Then people will start paying attention and say, actually, you know what, it's not all about cheating on essays with ChatGPT.
Exactly.
It's not about our data being stolen to go, I don't know where, fraud and all these other things. It's not about that. There is a bigger picture. And maybe it comes down to just how we package it.
Exactly. True.
Call to action.
So, okay. I think one, for policymakers, regulators, saying no and just this will not change. AI is already here. It's already being used. You need to improve your capabilities. All the different regulators need to improve their capabilities in assessing and understanding these systems. Not just to say no, but to also guide the use, because they're here to stay. They're not disappearing. To the young people, please, you can learn this by yourself. Try and learn it. Experiment. Things can be done. In terms of where the money will come from, you'll cross that bridge. But the demand for, the pitch here is, honestly, AI can improve so many things. So, and it is applicable in so many areas. We just need more implementers, users to actually do it. So for young people, please, you can learn this, try to experiment, learn a little bit more about statistics and actually start using this. You'll actually be impressed with what can actually happen. For us as public health practitioners, I don't think we should wait for the West. And there's no waiting. Like, for us, AI is not going to come on this silver platter. It'll be pushed by these different market forces because we have a huge demand for it, and these things will actually make that difference. So maybe that's my simple call to action. And maybe the last point is you talk to your dad, I talk to my dad, because
we confirm this similarity.
Who is who here? Yes.
I tell you, we have to, You know what I'll add? The young people, they do need to take advantage. And I know we always say that, you know what, we need to find the money and whatnot, right? But it's always how you package it, right?
Exactly.
It's, having been an entrepreneur in this space, right? It's packaging, right? Being able to, the example of you go to the insurance company and say, you know what, I'm developing, it will save you this much. You pay me pole like this, whatever it is. You start from somewhere. You don't have to wait, And then when you make it, don't forget us on the One Health podcast. Remember me and Anthony over here when you make it.
You had it here first. Yes. I drink coffee. I'm cheap.
I cannot say the same thing. Okay. Thank you so much, Anthony. You have to come back.
I definitely will.
Yes, absolutely.
With new improvements, and we can continue this conversation.
Absolutely. Even with a young person who perhaps you've,
mentored. Maybe you'll put my link on the...
exactly. Yes. Follow him for DM.
Yes. I'm actually happy to have conversations with
it's
some
important.
Of the listeners.
It's important. I think really, it really is, right?
Okay. Asante sana.
Asante.
Yes.
Join us next time on One Health Lens podcast.